wanted to thank you all so much for tuning into my channel. I'll always keep my videos here for free. The only thing that I ask from you is to like and subscribe my channel. If possible, please leave a comment below. Thank you so much. So today's topic is diabetic ketoacidosis. This is me, your host, Dr. Abhishek Tamrakar in Med Easy, where medicine is easy. So let's move on with the topic. Moving on with the topic, first of all, the definition of diabetes mellitus. Diabetes mellitus is defined as the HbA1c level of more than 6.5%. We must consider that it should be tested in the laboratory using a method that is NGSP certified and standardized by the DCCTSA, or the fasting blood sugar of more than 126 mg per dl. The fasting is defined as no caloric intake for at least 8 hours. We must be concerned with that. The 8 hours is the benchmark. The postprandial blood sugar, that is 2 hours of plasma blood glucose more than 200 mg per dl during an OZTT. This test should be performed as described by the World Health Organization using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water. The other criteria is in a patient with classic symptom of hyperglycemia or hyperglycemic crisis, a random plasma glucose of more than 200 mg per dl. So these are our criteria to mention it as a diabetes mellitus. Moving forward, what are the pathophysiologies for diabetes ketoacidosis? Secondary to insulin deficiency, we must not forget that the main culprit for this diabetic ketoacidosis is insulin deficiency. Secondary to insulin deficiency and the action of counter-regulatory hormones, blood glucose increases leading to hyperglycemia and glycosuria. Glycosuria causes osmotic diuresis leading to water and sodium loss. In the absence of insulin activities, the body fails to utilize glucose as fuel and uses fat instead, and this leads to ketosis. The excess of ketone bodies will cause metabolic acidosis. Later is aggravated by lactic acidosis caused by dehydration and poor perfusion. Vomiting due to ileus plus increased insensible water loss due to tachypnea, because the patient of diabetic ketoacidosis usually presents in your ER with a tachypnic. They are usually tachypnic. There is some kind of electrolyte abnormalities and secondary to their loss in urine and transmembrane alteration following acidosis and osmotic diuresis. I hope we are all getting it to the point. Moving forward, because of acidosis, the potassium ions enters the circulation leading to hyperkalemia. This aggravated by dehydration and renal failure. We must not forget that in diabetic ketoacidosis there is instant hyperkalemia and it becomes hypokalemia at later instant. So for the treatment we must consider the equation between both of this. We initially there is hyperkalemia, and in later part when heart utilizes the potassium, the state of body is hypokalemic. So for the management, I'll explain it later on as well, but for the management we have to keep potassium also, so don't get confused. Initially there is hyperkalemia, later on there is hypokalemia. All right. So depending on the duration of potassium DKA, serum potassium, a diagnosis may be high, normal or low, but intracellular potassium stores are always depleted. That's the thing that I had earlierly said. There is phosphate depletion will also take place in metabolic acidosis. Sodium loss secondary to hyperosmotic state and the osmotic diuresis. The dehydration can lead to decreased kidney perforation and acute renal failure. Accumulation of ketone bodies contributes to the abdominal pain and vomiting. There is increased acidosis leading to acidotic breathing and acetone smell in the breath of eventually cause impaired consciousness and coma. Just analyzing the slides from earlier above, there are lots of things that you have to be careful about regarding the signs and symptoms of the diabetic ketoacidosis. Being an emergency medical personnel, you have to take care of the each and every significant signs that you have seen throughout it. The patient complains of pain, abdominal pain. The patient complains of vomiting. The patient complains of acidotic breath. We have to be concerned about that. We must send the necessary investigations. We must do the necessary protocols. And for that, we must be learning the pathophysiology of the disease. For that's the reason I have included the pathophysiology. Moving forward, what are the precipitating factors that most cause the diabetic ketoacidosis? The first is type 1 diabetes mellitus. It has been evident that 25% of the people are having diabetic ketoacidosis, the one who have type 1 diabetes mellitus. Second is the diabetic patient having infection. That's about the 40% of the total people. The third one are the people who take steroids. People who take steroids, thiazides, dobutamine medication, and terbutaline. Usually, people suffering from diabetic ketoacidosis are the ones who have missed their insulin dose. About About 20% of them are the ones because of non-availability of the insulin medications, because they belong to a poor country. They have fear of hypoglycemia. They skip the insulin dose as they haven't eaten anything. For that reason, with the fear of hypoglycemia, there are the rebellion of the authorities. They are the ones who do not work with the medications, the regimen that we have given. There is a fear of weight gain. People have got the misconception that insulin increases weight, and there are some reasons of stress of chronic disease, and they do not take insulin, thinking that it will end up into a chronic state. So, for the diagnosis of diabetic ketoacidosis, you should suspect diabetic ketoacidosis if a patient presents with dehydration, acidotic breathing with a fruity smell, abdominal pain and distension, vomiting, and altered mental status. For the diagnosis of diabetic ketoacidosis, the following criteria must be fulfilled: hyperglycemia of more than 300 mg per dl and glycosylturia, ketonemia and ketonuria, metabolic acidosis of pH less than 7.25, sodium bicarbonate less than 15 mmol per liter, and anion gap of more than 10. Anion gap is calculated as per sodium and potassium aggregated total amount and deducted with the negative ions like chloride and bicarbonates. This is usually accompanied by severe dehydration and electrolyte imbalance. Regarding the management of diabetic ketoacidosis includes a sequelae of management, assessment and cause. and sequelae of diabetic ketoacidosis by taking short history and performing a necessary scan examination. Quick diagnosis of diabetic ketoacidosis at ER, baseline investigations, treatment monitoring and avoiding complications, transition of outpatient management. Regarding the history, so what needs to be asked in the history? The symptoms of hyperglycemia, the precipitating factor that we have earlier discussed, whether the patient is having diabetes or not, whether the patient is a sufferer of type 1 diabetes or not, has he or she been using insulin or not, we have to be considered about that. Examination. Look for signs of dehydration, acidosis, and electrolyte imbalance. Include shock, hypotension, acidotic breathing, CNS status, etc. Look for signs of hidden infections like fever strongly suggest infections, and if possible obtain accurate amount weight before starting the treatment. So what are the baseline investigations that we must send? Yes, that's true. We have to send the plasma and urine level of glucose and ketones. We have to do the ABC and urine analysis of sodium, potassium, calcium, magnesium, chloride, phosphate, and bicarbonates. And if possible, we have to take the arterial pH. I do not want to say that the venous pH is anything lesser, but if possible, take an arterial pH. But even if there is, if we cannot locate the arterial pH, we can consider the venous pH with an error of 0.025 less than arterial pH. We need a complete blood count with differentials just to rule out infection. And the further tests that we must do are the X-rays, culture of X-rays and culture, blood cultures and urine culture just to rule out the infections. So what are the pitfalls for diabetic ketoacidosis? High white blood cell count may be seen in absence of infection. Blood urea nitrogen level may be elevated with prerenal azotemia secondary to dehydration. Creatinine, some assays may cross-react with ketone bodies, so it may not reflect the true renal function. Serum amylase level is often raised and there are abdominal pain. A diagnosis of pancreatitis may mistakenly be made. So what would you do for the treatment? Regarding the principle of treatment, we have got few basic modalities, and those are careful replacement of the fluid deficits. As there is fluid deficits, there is vomiting, there is sweating, there is excessive perspiration. We must be careful regarding the fluid deficit correction. Correction of the acidosis and hyperglycemia via insulin administration. Correction of electrolyte imbalance, treatment of underlying cause. Monitoring the complications of treatment, managing diabetic ketoacidosis in the ICU. If not available, it must be managed in a special care room and as inpatient ward. Here is a chart that is describing the use of diabetes, how it should be treated, how a diabetes patient should be treated. I have included the fluid support, insulin support, potassium support, and excess of bicarbonates. Now I would like to discuss regarding the management of diabetic ketoacidosis. After the complete initial evaluation, check capillary glucose and serum urine ketones to confirm hyperglycemia and ketonemia and ketonuria. Then, if the ketone is positive, then we have to start on IV fluid 1 liter of 0.9% normal saline per hour. There are basically four main parameters that we have to be managed during the management of diabetic ketoacidosis. First being the IV fluid part, second being the insulin, third being the potassium, and fourth being the bicarbonates. In the further lecture, I will be discussing each one of them briefly. Uh, we can you can easily get the slides in the comment section below. I will make it providable. Now starting on the IV fluids. What we have to do with the IV fluids? We have to first of all we have to determine the hydration status, whether the patient has got severe hypovolemia, is mildly dehydrated, or has the cardiogenic shock. After that, if the patient is has severe hypovolemia, then we have to administer 0.9% of normal saline. If the patient is mildly dehydrated, then we have to evaluate the serum corrected sodium. But if the patient has got cardiogenic shock, that means he is not responding well with the management, he is not responding well, then we have to monitor the hemodynamic status and the blood pressures. After dealing with all these factors, we have to evaluate the corrected serum sodium level. If the serum sodium level is high, then we have to start in 0.45% of normal saline at 250 to 500 milliliters per hour, depending upon the hydration status. If the serum sodium level is low, then we have to start on 0.9% of sodium chloride, that is normal saline, 250 to 500 ml per liter per hour, depending upon the hydration state. After all that being done, we have to look when the serum glucose reaches 200 mg per dl, change the 5% dextrose with 0.45% of normal saline at 150 to 250 milliliters per hour. Now, regarding the insulin, insulin can be given in two routes. First of all, it's the IV route, and the second one is the IV route, and the second one is the uncomplicated subcutaneous route. Regarding the IV route, insulin can be given as regular insulin 0.1 unit per kg body weight as IV bolus, and after that 0.1 unit per kg per hour IV continuous insulin infusion. Regarding the subcutaneous route, we can give a rapidly acting insulin at a rate of 0.3 unit per kg body weight, then 0.2 unit per kg 1 hour later. Rapid acting insulin 0.2 unit per kg subcutaneous every 2 hours. If the serum glucose does not fall by 50 to 70 mg per dl in first 4 hours, double the IV or subcutaneous insulin bolus. When serum glucose increases to 100 mg per dl, reduce regular insulin infusion to 0.02 to 0.5 unit per kg per hour IV, or give rapid action of insulin at 0.1 unit per kg subcutaneous every 2 hours. Keep serum glucose between 150 to 200 mg per dl until resolution of diabetic ketoacidosis. Similarly, after the management of the requirement insulin, we have to manage the potassium value. But before managing the potassium value, we have to establish what is the renal function, because it is the parameter that gives out the status of potassium in our body. So for this, we have to establish renal function, that is the urine output of about 50 ml per hour. If serum potassium is less than 3.3 MEq per liter, hold insulin and give 20 to 30 MEq per liter potassium more than 3.3 mEq per liter. If potassium is if potassium is more than 5.3 mEq per liter, do not keep potassium but check serum potassium every 2 hours. If serum potassium is more than 3.3 but less than 5.3, 20 to 30 mEq of potassium in each liter of IV fluid to keep serum potassium between 4 to 5 mEq per liter should be added. In this way, we can manage the potassium. And one thing to keep in mind, if the potassium is not managed properly, then a patient could land up in a cardiac arrest, and which could be the most dreadful condition while managing diabetic ketoacidosis. The fourth factor that we have to manage are the bicarbonate level. The bicarbonate level, the only factor that determines the bicarbonate level is the pH of the blood. If the pH is less than 6.9, then we have to dilute sodium bicarbonate in 400 ml of water with 20 mEq of potassium. Infuse it for 2 hours. If pH is more than 7.4, then we can directly administer sodium bicarbonate. Later, after uh, 2 hours, we have to repeat the sodium bicarbonate administration every 2 hoursly until the pH is more than 7. Then we have to monitor potassium value as well, because it will eventually cause hyperkalemia. After everything is done, we have to check for the electrolytes, blood urea nitrogen, venous pH, creatinine and glucose every 2 to 4 hoursly until stable. After resolution of diabetic ketoacidosis and when patient is able to eat, initiate subcutaneous multiple dose insulin regimen. Continue IV insulin infusion for 1 to 2 hours after subcutaneous insulin began to ensure adequate plasma insulin levels. In insulin naive patients, start on 0.5 unit per kg to 0.8 unit per kg body weight per day and adjust insulin as needed. Look for participating cause. So guys, this is the end of the lecture. Please like and subscribe the YouTube channel for more made easy videos. Please like and follow the Facebook page and the Instagram in the description below for slides and more medical updates. Free digital OPD is available via the Facebook page.